Everyone, today we'll discuss the premature ovarian insufficiency, that is POI. This is a 2024 recent guidelines. This is the 2024 recent guidelines of ESHRE 2002. I'll discuss all this 2024 recent guidelines on the premature ovarian insufficiency. So I'll discuss each and every guideline points. So what are the key recommendations of the premature ovarian insufficiency? If you see, there will be the part A is the premature ovarian key question. What should this condition is called? The guidelines group recommends that the premature terms means, what is the terms means? It will usually is the condition in research and clinical practice. How should you define the premature ovarian insufficiency? This is the conditions defined by very very important statement. The conditions defined by loss of ovarian activity before the age of 40 years. First statement, before less than 40 years. They are the first statement they have told in the guidelines, that is a premature ovarian insufficiency. You have to define this condition by defined by loss of ovarian activity before the age of 40 years. Okay. Then premature ovarian insufficiency is characterized by amenorrhea or irregular menstrual cycle. Amenorrhea or irregular menstrual cycle with elevated, very very important. The condition has to be satisfied all these conditions. Amenorrhea or irregular menstrual cycle plus elevated gonadotropins and low estradiol level. So very very important, elevated gonadotropins like your FSH, and there will be a low estradiol level. Okay, so very important how to define premature ovarian insufficiency. The condition has to be there, defined by loss of ovarian activity before the age. The age criteria is less than 40 years, and there will be amenorrhea or irregular menstrual cycle along with elevated gonadotropins, that is FSH will raise, and low estradiol level. So in this guideline, the suggestions of ovarian function in women aged from 40 years and less than 45 years will be termed as early menopause. If you see so many patients 40 to 45 years, if there will be early menopause, that will term as early menopause. So remember the statement, 40 to 45 year is termed as early menopause, not POI. Okay, before 40 is the target cutoff. So early menopause is not to discuss here. The key question, what is the prevalence of POI? The preferred prevalence is non-iatrogenic POI is very approximately 1%, and in older studies to 3.5%, approximately 1% in older studies to 3. Now the recent evidence, the non-iatrogenic, it is not induced by any medical methods or surgical methods, it is non-iatrogenic. So it is now increased to 1 to 3.5. Previously it is 1%, now it is increased to 3.5%. Okay. What are the risk factors? The guideline recommends the view of long-term health consequences of POI. Efforts should be made to reduce the risk of POI. Modifiable factors may include, these are the gynecological practice, lifestyle such as smoking, these are risk factor, and treatment regimen for malignant chronic diseases. The guideline group recommends that women with risk factors of POI identify counsel for fertility projections and the risk. Okay. So how will diagnose? The guideline recommend the healthcare professionals about the symptom. They should inquire about the symptoms of estrogen deficiency, and when present with those, usually how will diagnose these cases? You have to think about those patients came with less than 40 years with estrogen deficiency symptoms and with irregular menstrual cycle and amenorrhea, and always try to consider and exclude the diagnosis of POI is the age less than 40 years who have amenorrhea, irregular cycles, estrogen deficient symptoms. What are the investigation you should perform for the diagnosis? Investigation to perform should be presence of symptomatic amenorrhea, biochemical confirmation has to be needed. The guideline group recommends following diagnostic criteria: the disorder of menstrual cycle, that is spontaneous amenorrhea or irregular menstrual cycles, at least 4 months. Very very important. There will be a diagnostic criteria include irregular menstrual cycle at least 4 months plus an elevated FSH, that will be the cutoff level, very very important, 25 international unit per liters. So first statement, the guideline recommends the diagnostic criteria is disorder of menstrual cycles, that is spontaneous amenorrhea or irregular menstrual cycles for at least 4 months, and an elevated follicle stimulating hormones, that is more than 25 international units FSH. And FSH assessment, very very important. How will assess FSH assessment should be repeated. How will repeat? This should be repeat after 4 to 6 weeks, that means 1.5 months. You have to, if there is a diagnostic uncertainty, so only if there is a diagnostic uncertainty, the FSH assessment should be repeated after 4 to 6 weeks. Okay, the FSH testing for the diagnosis of POI does not have to be timed to a specific day of the, you can do any day of the cycles. It is not specific to a timely manner, it can be done at any times. Okay, the guideline group recommend that these are the considered diagnosis. To when you consider this diagnosis of POI, the pregnancy should be, first thing you have to do, UPT, urinary pregnancy test, has to be excluded in women presenting with amenorrhea. And then you have to exclude the use of hormonal therapy, including oral, injectable, long-acting contraceptive may conceal or cause amenorrhea, because if they are taking OC pills or injectable contraceptive methods or oral contraceptive or long-acting DMPA or any LNG IUD, there will be chances of amenorrhea or irregular cycles. Potentially that will cause lower FSS concentration. Some hormone therapy like combined occipitals may need to be ceased before going diagnosis of a POI. So very important, all the drug history is very important in case of diagnosis of pre-OI. So basically OC pill, injectable, contraception pill and long-acting LNG IUD, all this has to be excluded when you go for a diagnosis. Has to be ceased if you started some hormonal therapy, may need to be ceased before a diagnosis of POI confirms. Women had a bilateral BSO before age 40 years have a diagnosis of POI. Additional diagnostic testing is unnecessary, because here already they have a BSO, so no need to do all this diagnostics testing. If they have already already done BSO, that itself it indicate there will be a loss of ovary both side, so no need to do any diagnostic test in that case. Okay, very important statement, no need to do any diagnostic testing is unnecessary. The guideline group does not recommend the POI based on serum estradiol case. Okay, so basically the diagnosis is not based on the serum estradiol level. The concentrations, it doesn't recommend it to do a serum estradiol to diagnose a case. But however, if there will be a low estradiol concentration, it indicates that it means patient is hyperestrogenism. So should estradiol level is used for diagnostic criteria? No, it is a wrong things. Don't do estradiol to get a diagnosis of POI, but if you get a low estradiol concentration, it means it indicates hypoestrogenism. It will help in combination with elevated FS concentration. It provides additional confirmations. Okay, but if usually not recommend, but you can do estradiol level to additional confirmation to get a POI diagnosis. Okay, what is the role of AMH to predict diagnosis? Anti-mullerian should not be used. Very important, not to be used for primary diagnostic treatment. For POI, the guideline recommend AMH testing may be useful to confirm POI diagnosis, whereas FSH, if you get FSH results is inconclusive, if FSH is inconclusive, then you go for a serum if FSH is inclusive, then you can go for a serum AMH level. In that cases only it has a clinical context. So the guideline recommends that don't routinely perform all these AMH, perform AMH due to insufficient evidence of accuracy. What are the known cause of non-iatrogenic and how should we investigate? The guideline recommends the women with POIs, the different cause of POI, the limitation current knowledge testings. The guideline recommends discuss the implication of genetic testing before the test is performed. The chromosomal analysis testing is recommended. All very important. All women's with POI. With POI non-iatrogenic, the FMR gene mutations for all women with non-iatrogenic FMR1 gene mutation has to be done. That is the Fragile X syndrome. It is associated with Fragile X syndrome. So where it is available after comprehensive genetic testing, counseling, additional genetic testing. The genetic testing, next generation sequencing can be offered to all women with non-iatrogenic POI to identify other potential genes that may cause POI. So the guidelines recommend that the age of a woman with POI should not be used to restricted access to genetic testing. You should not restrict. The screening for 21 hydroxylase auto antibodies should be performed women with unknown cause. Screening anti-ovarian antibodies should not be used to diagnose autoimmune POI. So the TFT thyroid function should be assessed measuring TSH level at POI diagnosis. Wherever TSH has to be determined to rule out autoimmune. TSH measurement should be repeated every 5 years or when symptoms rise. The guideline recommends Not routine to perform TPO antibody screening as a part of testing for autoimmune cause of POI due to high prevalence of positive anti-TPO. The woman with POI should be a POI with a positive 21 hydroxy antibody should be referred to an endocrinologist for testing adrenal functions. Very very important. If you get a POI plus 21 hydroxylase antibody positive, then you have to go to rule out adrenal failure. 21 hydroxylase positive antibodies. 21 hydroxyl antibodies negative women with POI. There is no indication to risk testing later in life unless signs symptoms adrenal insufficiency develop. Women with POI abnormal TSS levels should be if elevated treated thyroid hormone disorder. I also recommend that the guideline recommends decision makings. Identify genetic causes of POI should be offers genetic counseling testing. Females relatives such as sisters, daughters, women with non-androgen POI should be counseled that their sister, daughter also increase risk of POI. The signs symptoms should be explained, and the sequelae of POI very very important. What are the sequelae of POI? The women POI should be informed that POI without hormone replacement therapy associated reduced life expectancy largely due to cardiovascular. Very very important. The cardiovascular disease will be increased if it is early premature or an insufficiency. The guideline recommend that a woman with POI should be until the use of menopause. Very very important statement. Now the hormone replacement therapy is recommended for women with POIs until the usual age of menopause. You have to give hormone replacement therapy. This is the very important statement to primarily reduce the risk of morbidity, mortality, whether they are estrogen deficiency symptoms or not. The guideline group recommend that the women with POI should be encouraged to adopt healthy lifestyle, including avoid smoking, having healthy diet, regular physical activity, maintaining healthy weight range to reduce cardiovascular risk. So, women with POI should be informed that substantially reduce the chances of natural conceptions. Non-surgically POI should be informed that ovarian activity may occur. This has the chance of natural conceptions. With women with non-surgical POI should be advised to use contraception if they want to avoid pregnancy. They can use contraception also. What fertility intervention is effective? POI should be informed no intervention that have been effective. Basically, you have to advise to oocyte donations. Iatrogenic cause of POI, fertility preservation can be considered prior to the treatment. The guideline recommends fertility preservation discussed with women with POI, and oocyte donation pregnancy are high risk. Turner syndromes are high risk of studies. Pregnancy should go for a oocyte donations. Okay. The comprehensive cardiac screening, appropriate counseling, both maternal and fetal medicines should be done. Usual antenatal screening, women POI should have their cardiometabolic thyroid functions assessed prior to pregnancy. Though what are the consequence? Skeletal health. Usually it associated abnormal bone microarchitecture, reduced bone mineral deficiency, increased risk of osteoporosis, fracture in the later lives. Osteoporosis risk factors identify, address during the ongoing care, including weight bearing exercise, avoid smoking, maintain normal body weight. Dietary supplementation like calcium, vitamin D3 in women with inadequate vitamin D status. Calcium may benefit with low mineral. HRT is recommended to maintain bone mineral, prevent osteoporosis. The daily dose of hormone replacement therapy very very important, containing no less than you have to give 2 mg estradiols or 100 microgram. If you give oral, then 2 mg. If you give a transdermal route, transdermal estradiols, it is 200 micrograms. Very very important. 2 mg oral estradiol, 100 microgram transdermal. Delays initiation should not be done to be avoided. Non-adherence to be avoided. If the combined oral contraceptive used, the continuous or extended recommended regimen to be recommended to provide continuous estrogen therapy and avoid bone loss. Other pharmacological, very very important. If you give OC pill for hormone replacement therapy, then you have to go be a continuous therapy. Don't interrupt, because you have to supply continuous estrogen therapy here, and an extended regimen like 1 year, 2 years, 3 years, 4 years till the natural menopause. Avoid bone loss. Other pharmacological treatment including bisphosphonates should only be considered advice from osteoporosis specialist. And where the available, what are the tests to be done for the skeletal health? You have to do bone mineral density. Usually dual DEXA scan has to be done, and for all women, if bone mineral density is normal, adequate systemic HRT is recommended. Added to the value repeated DEXA scan within 5 years low. The bone mineral DEXA should be reassessed every 1 to 3 years. You have to do 1 to 3 years DEXA scan based on individual risk factors. Then it says that the reduced muscle mass, strength, performance exercise, the healthy lifestyles already I talked about this, and the effect of other interventions like include testosterone therapy on the muscles of health of men is uncertain, and the how should muscle health is to be recommended. The group recommend that should be considered screening sarcopenia at the diagnosis. Women with POI should be aware they are increased risk of cardiovascular disease, coronary, CVD, coronary artery disease, and heart failures and stroke. These are the risk factors they have to explain. All women diagnosed with Tourette syndrome should be evaluated cardiologists to detect congenital heart disease as well as prior to during pregnancy. Non-use of HRT actually increases cardiovascular events, mortality recommended until the use of menopause. Should cardiologist monitor? Okay, the guideline group recommend the cardiovascular should be assessed. Recommend that including avoid smoking, heart healthy already told, annual monitoring of blood pressures, weight, smoking tasks has to be done. They have to, very very important, lipid profile has to be done in POI cases. Okay. Then significant psychological well-being, all these things can significant sexual well-being also. The where available transdermal testosterone therapy in dose that approximate physiological premenopausal testosterone consider can be considered. It may improve if you have a hypoactive sexual desire disorder, sexual desire, loss of libido, then in that case you go for transdermal testosterone therapy. Okay. That hormone depression prescribed 2 minutes POI indication may improve sexual functions, generally small. What are the treatment available genitourinary symptoms? If you have vaginal estrogen therapy, if you give a vaginal estrogen therapy, you can give. When POI offer vaginal estrogen therapy in genitourinary symptoms not fully relieved by using system. If you started systemic ST hormonal replacement therapy, if not removed, then you go vaginal estrogen therapy. Vaginal lubricant moisturizer can be used for treatment of vaginal discomfort, dyspareunia. The guideline does not recommend laser thermal energies for standard care of GUS. And what are the effect of neurological cognitive effect? Increase risk of cognitive neural impairment, risk of dementia, Parkinson's, Alzheimer's, other neurological disease should be discussed when planning for bilateral reproductive under the age of 45 years. So very very important, if you go for a BSO, so you have to discuss the cognitive impairment defect, cognitive impairment defect, dementia, Parkinson's, neurological disorder. What are the management options for the POI? Cognitive is recommended until the use of natural menopause. You have to go for HRT and to protect neurological functions in the absence of neonatal symptoms. All these healthy lifestyles. POI treatments, basically the treatment is the hormonal therapy women with POI until the use of natural menopause for primary prevention to reduce the risk of morbidity, mortality, whether there is estrogen deficiency symptoms or not. So very very important statement here. They told whether they have symptoms or not symptoms. Very important statement. Whether estrogen deficiency symptoms is present or absent, regardless of the symptom, you have to give HRT. Regardless of symptoms present or absent, you have to give HRT till the usual natural age of menopause, that is your 45 to 47 years. So women with POI should be advised HRT recommended about the treatment symptoms due to low estrogen concentration. The guideline continue personal risk benefit assess to be done. Then the guideline group recommends the question risk of hormone therapy. No evidence that increase risk of breast cancers. Okay. Then women same as group. HRT is generally not recommended in women with history of breast cancers. So usually if there are a history of breast cancers, you should not go for a HRT therapy. In that case, not recommended. Women with BRCA1-2 mutation without personal history of breast cancer should advise HRT as an option after risk reducing salpingo-oophorectomy. Okay. So if there are no personal history of breast cancers, if a history of breast cancer, so HRT should not be given. If there will be a history of breast cancers without personal history of breast cancer with a BRCA1-2 mutations, your chances of risk is high. So in that case, HRT should be started after risk reducing salpingo-oophorectomy. A progesterone should be given in combination with estrogen therapy to all in the intact uterus to prevent endometrial hyperplasia and cancers. Already everybody know the dose of progesterone increase, higher dose estrogen therapy are used. The on-cycle bleeding require assessment with any women using HRT. The POI patients, if there is on-cycle bleeding, those should assess. Then go for a assessment. Combine estrogen progesterone even after hysterectomy to avoid recurrence of endometrial malignant transgression. So very very important statement here. If those patients with POI with history of endometriosis should be treated with combined estrogen progesterone therapy even after hysterectomy, because you know endometriosis there will be a recurrence. So you have to give both estrogen plus progesterones malignant transformations to avoid recurrence of endometriosis. So in the case of endometriosis with POI, you have to go estrogen plus progesterone therapy even after hysterectomy done. So very very important. Migraine should not be considered. Migraine is not a no longer is a contraindication. Migraine is not a contraindication. Changing dose, consider changing dose, route of administration If migraine or only you have to change the dose and the route of administrations of regimen if migraine worsen during HRT. If it is worsen, then only change the HRT dose and it route, but it is not a contraindication to HRT. Okay, women with POI, migraine with aura should be advised to use transdermal estrogen, as this may lower risk route of administration. So if you have migraine with aura, then you go for a transdermal HRT. Transdermal HRT, not this lowest risk route of administrations. So basically, the role of testosterone therapy already told. Consider women with iatrogenic EPOI to manage hypoactive sexual desire. Testosterone treatment could be considered non-androgen period to manage hypoactive biphysical profile. We transfer dose. It will not increase the recurrence risk of, does not increase the recurrence risk of squamous cell carcinoma of the cervix. Maybe associated slightly increased the recurrence of cervical adenocarcinoma, a personal approach. Adenocarcinoma slightly raised, but not as well squamous cell carcinoma. It will not increase the risk of squamous cell, but slightly raised adenocarcinoma. So we are in the early stage low risk of endometrial carcinoma. Due to early stage low risk endometrial carcinoma, there is no increased risk of recurrence. Due to epithelial ovarian can be considered in epithelial. So basically, the adenocarcinoma type you can avoid. Hormone dependent ovarian cancers like uterine tumor, uterine sarcoma, endometrial carcinoma, ovarian clear cell carcinoma. Okay, if you like this content, please subscribe. Last part I'll just do some left part I will discuss in the next part too. Thank you. If you like this content, please subscribe. Thank you.